Okay, hello. My name's Kate. I'm one of the junior doctors over at St James's. I'm doing respiratory at the moment. I don't know why I've put the 14th of the 3rd, because it was never on the 14th. I wish it's the 11th today. I'm going to talk to you for about 45 minutes about endocrinology. I'm not going to claim that I'm any sort of expert. I've obviously only got kind of final level knowledge as well, because I've not done an endocrine job. I've not even really done a general medicine job. But I didn't train in Leeds, so I'm sorry if my lecture doesn't exactly match up with your syllabus, but I did have a read through it, and I've kind of based this on what I would have revised for finals, so I hope that that's a reasonable level for you guys. Obviously in 45 minutes I can't cover everything, so I've covered what I think are the main things, and hopefully it gives you a little bit of an outline at least, so when you are revising it gives you something to refer back to look at what you think you might need to know, what you need to look at further. Is that all right? Is that what you've mostly had from other people in these lectures? And obviously you're expecting Pete first to talk about transfusion and haematology, but he's still at work, so I'm going to go first. So aims and objectives. I'm going to outline the core endocrine topics. So we're going to first look at diabetes, and then thyroid disease, adrenal disease, pituitary disease. I'm going to have a quick talk about some other conditions that you may or may not need to know about, but I'm not going to cover them in detail, and then I've got just a few questions at the end. So, to begin with, diabetes, something that always comes up in exams, type 1, type 2, and then there are the kind of the familial types of diabetes and the gestational diabetes as well. There are lots of NICE and WHO guidelines on diabetes, both type 1 and type 2, and gestational diabetes. If Leeds is anything like Sheffield Medical School, they're very keen on asking you all sorts of things that are kind of based on the NICE guidelines and the WHO guidelines, so I guess it's worth maybe having a look at those at some point. So type 1 diabetes used to be called insulin-dependent diabetes. It's obviously autoimmune disease, B-cell destruction in the pancreas, and the B cells produce insulin, so it's primary insulin insufficiency. The presentation is characterised by the classical weight loss, hypoglycaemia, ketoacidosis, polydipsia, thirst, all of those things that you classically associate with DKA. We're going to talk about diabetic emergencies in a little while, but that's kind of the classic presenting complaint. It's often associated with other autoimmune diseases, so classically things like thyroid, vitiligo, often runs in families, not necessarily the diabetes, although that can, but also the kind of the autoimmune kind of type of family. There are often you can if it's unclear as to whether often this is a very clear diagnosis, but if it is unclear as to what it is, you can do autoantibodies, so there will be islet cell autoantibodies and anti-glutamic acid autoantibodies as well. Typically juvenile onset, so anything between kind of 3 and 12 is classical, but can be onset any time during life. Type 2 diabetes, so reduced insulin production, but primarily insulin resistance. The kind of classical, often think of a kind of a late middle-aged or elderly man, quite overweight, associated with the kind of impaired glucose tolerance coming on over a number of years. Hyperglycaemia, which is often asymptomatic, and associated with more kind of chronic complications in the type 1, as I said, typically later onset, although there are kind of ongoing concerns about whether this is going to be something that we see in a younger and younger population, and we certainly see it on the wards in kind of 30 and 40-year-olds, especially people with other chronic diseases. And I'll talk a little bit more about the chronic disease management in a little while. it's higher in Asian populations. Some parts of England we're seeing kind of 20% prevalence in some communities now. So those are the two. Obviously type 2 is the most common. Type 1, I don't really know what percentage of the population, but other causes of kind of less common causes of the diabetes are drug induced, so secondary to steroids. We see that quite a lot when we're treating any kind of inflammatory conditions with steroids. Thiazide diuretics as well. It can be secondary to pancreatic surgery, so trauma, to pancreatitis, and also can be seen in association with other endocrinological problems, so with Cushing's disease, acromegaly, glycogen storage diseases, which glucose tolerance test is you give 75 milligrams of kind of short-acting carbohydrate, and then with in 300 ml water, and then test 2 hours later. You can also have kind of, as we talked about, different scales, so impaired glucose tolerance and impaired fasting glucose, which are slightly different borderlines for their blood sugars on testing. So moving on to treatment. Type 1, the mainstay of treatment, once you've kind of got over the initial emergency presentation, as it were, with DKA, is insulin. They're all different regimes. So now the most common regime to be on would be the carbohydrate counting, especially if you're presenting young and you're able to count your carbohydrates. And there's a 5-day, it's called a Daphne course, which people presenting with type 1 will go on, usually in the kind of early to mid-teens, when they're able to start really getting a grip on their own carbohydrate counting and kind of adjusting and adapting their insulin regime to that. So carbohydrate counting using short-acting insulin or very short-acting insulin, such as Novorapid and Actrapid, and then using a background of a medium or long-term insulin as well. There are kind of mixed insulins as well, so if you can give it in 1 injection or 2 injections, either once just in the morning or once in the morning and the evening, of a mixed insulin, which has the background and some short-acting in it as well, but obviously that doesn't achieve such a good control of your blood sugars. And then there are kind of new things coming in now where you can have a pump, which the kind of in trials looking at whether you can give it base. It can automatically feed back from your BMs itself, but at the moment you have a pump that administers a low level of insulin all of the time, and you can then count your carbohydrates and control your input that way. Type 2 diabetes, so you can start with diet control and then move on to oral hypoglycaemics. So the NICE guidelines change quite often, but at the moment the advice is that you start with a biguanide, so metformin, which increases insulin sensitivity, and it actually helps with weight loss as well, because that's another thing that we do with diet control, is try and get people to lose some weight, which can in itself help with their diabetic control. Metformin does not cause hypoglycaemia. Whatever people on the ward tell you, they say, oh, I can't take that when I've not eaten because I'll have a hypo. They won't. You have to be careful if you've got people who are poorly, so if you're looking at people on the ward who've been admitted with an intercurrent illness, something else wrong with them, say they've got pneumonia and developed AKI with acute kidney injury with that, you need to be careful if they're on metformin, because if their creatinine is over 150, you need to stop their metformin temporarily, because it gives you a risk of developing lactic acidosis. So if you're worried about that, how do you think you would measure lactate on someone quickly if you were worried about that? Yeah, ABG. Good. So if you don't achieve good control on metformin, you can add in glycoside, which instead of increasing insulin sensitivity, increases insulin excretion from pancreas, but that may cause weight gain, kind of associated with its mechanism of action, really. and a side effect of that can be, again, hyperglycemia, because you're increasing the insulin secretion. Then move on to sitagliptin, which again increases the insulin secretion and also suppresses glucagon release, and again can have a side effect of hyperglycemia. And then a new, I can't pronounce this, exenatide, is used in addition to metformin and sulfonylurea in people with a particularly high BMI, or in those when you haven't achieved good control on your first 3 oral agents. If for whatever reason insulin is inappropriate, then you can move on to this as well. Again, it increases insulin secretion, suppresses glucagon release, slows gastric emptying, and reduces appetite. So it's kind of got a multifactorial mechanism of action. And then if you're not achieving good control with all of these, the oral agents, or for whatever reason people are intolerant to them, because they do have quite a lot of side effects in terms of GI. People can get quite nauseous, have quite bad diarrhea and things on some of these. So, and then you move on to insulin to try and achieve good BM control. So another quite important element of diabetes is to try and manage the complications. So you have the complications, you need to think about micro and macrovascular disease. So in someone with who's had diabetes for a reasonably significant amount of time, the risk of having a MI goes up 3 to 5 times, and the risk of stroke is twice that of the average population. Causes kidney damage, and you can get diabetic nephropathy. So that kind of needs monitoring with annual albumin-creatinine ratio, creatinine monitoring, and also good really tight blood pressure control. So we aim for kind of 135 over 80 as opposed to the target for the main population, which is 140 over 90. Retinopathy needs to be screened for annually, so use drops to dilate the pupil and take pictures of the back of the eye, looking for any of the kind of the changes you get in retinopathy. And then all of the neuropathic complications, so they need an annual foot examination. Think about rarer things like gastroparesis. Again, with the vascular disease, you can get erectile dysfunction, and then bladder dysfunction with the neuropathy as well. And then with all chronic diseases, you need to think about depression in kind of secondary to that, because it can be quite, although lots of people, when you say, do you have any medical conditions, and they've got diabetes, they say no, because it's become such a part of their kind of background life. It can get people down, especially if they've got all of these complications. So if they have to come to hospital to see, people about their diabetic foot, and also to come to kidney clinic and everything else. So it can be people can get quite depressed, and that's something that we should be screening for every year. Again. So just quickly to talk about some diabetic emergencies. So first is hyperglycaemia. So it's defined by a BM of less than 3. Causes is usually insulin, so it's usually giving too much insulin for the blood sugar, but also sulfonylureas we talked about. Can be pituitary insufficiency, liver disease, liver failure, and then more very rarely islet cell tumour as well. Symptoms are kind of the classic hyperglycemic, sweating, anxiety, tremor, confusion, drowsiness, seizures, coma. Anyone who's found unresponsive on the ward, you should think about what's their BM. So A, B, C, D, E, obviously your normal assessment for kind of anyone unresponsive, but also think about do they have a low BM. So management, if the person is conscious and awake but with a low BM of under 3, but otherwise they're okay and they're able to swallow, then you should give them 15 to 20 grams of quick-acting carbohydrates, so something like just some fruit juice or Lucozade, or you can get the glucotabs on the ward. On every ward there'll be a BM box with a hypoglycaemia emergency bit, and then follow that up with long-acting carbohydrate. If they're conscious but confused and disorientated and not really able to eat and drink as such, you can give them 3 tubes of glucogel, and you can rub that into their mucous membranes as well, or 1 milligram of IM glucagon. Giving IM glucagon's not that nice, especially to kind of little old people with not much muscle to inject it into. And then again, follow that up with a long-acting carbohydrate when they start to come around. If they're unconscious or having seizures, then obviously start with your ABC assessment, but you again give a milligram of IM glucagon or 80 mils of 20% glucose IV. And again, once they come around, follow up with long-acting carbohydrate. Think about the cause, why did they have it, etc. Coming on to DKA, we spoke about briefly. So it's a common presentation of type 1 diabetes at the very beginning, or people with type 1 diabetes get it when they're otherwise unwell, so when they've got some sort of intercurrent illness, or if they're not particularly good at controlling their sugars. So it's a triad of hyperglycaemia, acidosis and ketonuria. Presents with the polyuria, polydipsia, severe dehydration, lethargy, hyperventilation, vomiting, abdominal pain and coma. So again, if you find someone, think about their blood sugars if they're unconscious, unresponsive. You should investigate by obviously doing the BM, doing an ABG, looking for that acidosis. Do their kind of full screen of blood. Are they septic? If they're spiking your temperature, or you're worried about infection, do cultures, urine dip, MSU. So you're kind of hunting for the cause of this DKA. And then the management is to get IV access as soon as you can, and then they need kind of aggressive rehydration. So the protocol is give them a litre as fast as you can, and then a litre in the first hour, and a litre over the second 2 hours, a litre in the next 4 hours. So, and then a litre over the next 4 hours after that. Obviously, carrying on assessing their fluid status and things, but and giving that alongside fast-acting insulin, and giving lots of fluid alongside insulin. You need to really think about their potassium, because insulin drives potassium from the circulation into the cells, so you need to be replacing that as well. And then they need to be on an insulin sliding scale, regular check of their blood sugars, their kind of acidotic state, and their U's and E's to keep an eye on their potassium. And then finally, so that's kind of the hyperglycemic state of type 1 diabetes. If you've got someone who's got type 2 diabetes, they, instead of getting this the classic DKA, they get this hyperglycemic hyperosmolar state, which used to be called HONK and is now called this, which again it's the hyperglycemia, severe dehydration and hyperosmolality, but they don't get the ketones in the urine, and they are often not as acidotic, and they present with confusion, altered consciousness and neurological signs, so can be weird focal signs, can be seizures, and again they can get polydipsia and polyuria. And again, like the DKA, it's usually triggered by an intercurrent illness, so it could be infection, MI, stroke. Any of these can drive someone who already has a propensity to have a hyperglycemic state, so if they're type 2 diabetic, into this state. And again, management is fairly aggressive rehydration, IV rehydration. Again, they need their electrolytes replaced, and they need to be on an insulin sliding scale as well. So moving on from diabetes, we've got, this is kind of looking at the kind of more general endocrine axis. So you've got the hypothalamus, which releases triggers for the pituitary, and those act on the end organ. So we're going to talk about a few of these now. So starting with thyroid disease. So thyroxine increases cell metabolism, and it's got a role in almost everything, which is why the features of it can be so, of thyroid disease, hyper or hypothyroid, can be so diverse. There are hundreds of symptoms. So just because pretty much all cells have the thyroid receptors. It plays a role in growth and mental development. So congenital hypothyroid can be quite severe learning and mental difficulties. It's controlled by this beautiful feedback loop. So if you've got in theory, if you've got low T3 and circulating T3 and T4, that'll drive up TSH, and obviously if you've got some problem in that loop, that's where you get thyroid disease. It's usually caused by a problem within the thyroid gland, as opposed to at a higher up level. So hyperthyroid, to begin with, is characterised by high T3 and T4 in the serum, and low thyroid stimulating hormone. Signs and symptoms are, as I said, there are hundreds of them. So the classic ones are kind of weight loss, tremor, sweating, being unable to tolerate heat, irritability, tachycardia, fine tremor, warm peripheries. People complain of kind of diarrhea and weight loss despite increased appetite, and then obviously you can get the things like a swelling in the neck, a goiter, things like that. Causes, again, quite a few. Graves' disease is the classic one, I guess. You can have a toxic multinodular goiter, which again is kind of obviously nodules in the thyroid, a toxic adenoma, so it's a single thyroid producing adenoma, subacute thyroiditis, so dicravians, which are often post-viral, and then drugs, amiodarone and lithium, as I'll say in a few minutes, they can cause hyper or hypothyroid, so be careful for anyone on those. They'll need to have their TFTs monitored. And then you can also have ectopic thyroid tissue in kind of organs other than the thyroid, which is the kind of the googly eyes. But you can also get optic nerve compression, ophthalmoplegia, so paralysed muscles, eye discomfort and grittiness, so people complain of having sore eyes. And so Graves' disease is caused by thyroid stimulating hormone receptor antibodies. And again, as we said earlier, with diabetes, it's commonly associated with other autoimmune diseases. So the four things that characterise Graves' disease are that the eye disease, you can get pretibial myxedema, which is I don't really know what it is, but it's changes on the tibia. Thyroid acropathy, which is you get finger clubbing, so it's it's a rare cause of finger clubbing and a painful periosteal reaction in your limb bones, and a thyroid bruit. So if you listen over the thyroid with the bell of your stethoscope, you can hear a bruit from the neck vessels. Management of hypothyroidism. So symptom relief especially for the tremor and the kind of the tachycardic symptoms. You can give a beta blocker, propranolol. Drug treatment, and so this is kind of almost like a ladder. So the symptomatic relief is a little bit separate though, because that's kind of to control the symptoms, and then to control the hypothyroidism itself, you can start with drug treatment, so carbimazole or propylthiouracil, and they bring the thyroid down. Obviously, if that doesn't work, or if you've got a cause that's more worrying, you need to if you've got like an adenoma or something that needs to be removed, then you can try radioactive iodide. That's logistically a little bit difficult sometimes. And then the kind of final step would be thyroidectomy. Obviously, with the radioactive iodide and the thyroidectomy, you've effectively stopped the thyroid from producing any thyroxine. So you're going to need to replace that with levothyroxine. So hypothyroid, again, really diverse, many signs and symptoms, but it's sort of the opposite. So you get bradycardic, dry skin and hair, non-pitting edema, slow relaxing reflexes, and peripheral neuropathy are things you might find on examination. Symptoms are kind of everything slowing, so tiredness, lethargy, depression, intolerance of the cold as opposed to the hot, weight gain, menorrhagia, hoarse voice, and the diagnosis is by low circulating T4, T3 and a raised thyroid stimulating hormone. The causes can be divided into autoimmune causes, so you've got primary atrophic hypothyroidism and Hashimoto's thyroiditis, and also acquired. So we spoke before about the post-surgery or the post-radioactive iodide, and then again drug-induced, we spoke about amiodarone and lithium can cause it, and then also iodine deficiency used to be quite a common finding in Derbyshire in hills, where apparently you don't get enough iodine. And the treatment is titrating up a dose of levothyroxine from 25 micrograms a day, and you titrate it up. People are commonly on kind of anywhere between 75 and 150 micrograms a day. Okay, so that's kind of thyroid disease. Moving on to adrenal disease. Adrenal glands produce steroids, and that's stimulated by ACTH from pituitary. And excess is generally Cushing's disease, and then deficiency, Addison's disease. We'll talk about both of those. Cushing's syndrome is the overall steroid excess, and the causes can be broken down into those that are dependent on too much ACTH or not too much ACTH, so ACTH dependent or independent. And then, so within that, you've got ACTH dependent causes are thyroid disease. So the whole, excess of steroids comes under Cushing syndrome. Cushing's disease is particularly pituitary adenoma secreting ACTH and causing bilateral adrenal hyperplasia. So you've got an adenoma in the pituitary gland that secretes too much ACTH, not in a feedback loop, and that causes hyperplasia of the adrenal glands, which kicks out too much steroid. You can have ectopic ACTH production, so sometimes found in small lung cell cancer and also in carcinoid disease. And then, for whatever reason, if you've got iatrogenic ACTH administration. And then if that's independent of ACTH, then you can have it from just us giving too many steroids, usually in treatments of an inflammatory disease that requires steroids, and then a side effect is developing Cushing's syndrome. And then you can also have adrenal adenoma or carcinoma, and then adrenal nodular hyperplasia. So the features of Cushing syndrome. So you've got the kind of the classic abdominal obesity. You get easy bruising of the skin, poor healing of any scratches and wounds. You get kind of proximal muscle wasting, and the truncal obesity with the skinny arms and legs. You get the what we call the moon face and a buffalo hump, which is a buffalo hump, which is kind of a fat pad across the back. You get thinning of the hair, and you can get acne and things as well. You can also get gonadal dysfunction and menstrual disturbance and impotence, and then, as we spoke about at the beginning, this impaired glucose tolerance. And if the pituitary adenoma is is affecting the optic chiasm, you can get a visual field defect as well. So it needs investigating with, so you start off with kind of a random cortisol and a 9 a.m. cortisol. Lots of people will say that that's fairly meaningless because cortisol it goes up and down during a circadian rhythm anyway. So usually you go straight on for a dexamethasone suppression test, So you administer a milligram of dexamethasone at midnight, and then measure cortisol and ACTH at 8 a.m. the next morning. In normal patients, that should cause negative feedback and low ACTH. If it's not respondent to that, then obviously you've got something wrong in the negative feedback loop. You can also do 24-hour urinary cortisol measurement. Obviously, if that's high, that's a suggestion that you've got too much cortisol. If any of these are abnormal, obviously that tells you that there's something wrong, but we can't really narrow it down often. So you need to do plasma ACTH. Is it high? Is it low? Is it independent? Is it dependent of ACTH production? You can do a high-dose dexamethasone suppression, which can, again, it gives you a bit more information about the negative feedback loop. And then you can move on to an MRI head. So, as we said, one of the common causes is the pituitary adenoma, so looking for that. And then a CT of the abdomen to get a good kind of imaging assessment of the adrenal glands themselves. The treatment depends completely on the cause. Obviously, if it's iatrogenic, you can stop steroids if possible. If you're treating an inflammatory condition, for example, something like inflammatory bowel disease, you can think about trying to start using steroid-sparing agents. It's obviously often quite difficult because we're all quite aware of this as a problem. So if people could be on steroid-sparing agents, they probably would be already. But if you can think about that, then that needs to happen. If you've got Cushing's disease, so that's the adenoma in the pituitary, then you need to remove it, and that's usually by a transsphenoidal approach. Adrenalectomy, if you've got adrenal adenoma or carcinoma, and then if you've got ectopic ACTH production, surgery to remove the tumour if it can be identified and if it hasn't spread. Obviously, small cell lung cancer often carries a fairly poor prognosis anyway, but that can be sensitive to chemotherapy. So thinking about things like that. And then you can use medical management to reduce cortisol. I'm afraid I don't know a huge amount about that. We talked about excess cortisol. Excess aldosterone is if you've got too much aldosterone being produced kind of independent of its own feedback loop, which is the renin-angiotensin system. And it causes, as it should do, if you want it to be released, retention of water and sodium, but obviously in excess. So you end up with hypertension, hypokaleamia. In the exchange of retaining sodium, you excrete too much potassium and moderately raised sodium. And that's, if you've got a solitary adenoma, then that's called Conn syndrome. But you can also have bilateral adrenal hyperplasia, which causes the same picture, but wouldn't be called Conn syndrome. And then the management of that is spironolactone. You can give, but that's got quite a extensive side effect profile. So amiloride and eplerenone are more modern drugs that hopefully don't give you the gynecomastia and other problems that spironolactone does. And then surgical, you can remove the adenoma if possible. Bit is a pheochromocytoma, which is uncommon but quite demonstrative. So it's a catecholamine producing tumour. And clinically it's diagnosed by signs and symptoms that are quite non-specific often, but if in a careful history you can pinpoint them as episodic. So you get intermittent hypertension, but when the patient is hypertensive, it's very refractory, it's very resistant to any treatment. You get sweating, heat intolerance, flushing, palpitations, kind of the classic fight or flight symptoms, and then feeling this fear of impending doom, feeling of apprehension, headaches, and then you can get visual disturbances. Investigation is by you have to do 3 of the 24-hour urinary catecholamine collection, and again abdominal CT really is kind of the mainstay of investigation, looking for any a tumour in the adrenals. And then treatment, you block the alpha and the beta, and then you can remove the tumour surgically if possible. Hyperglycaemia as well. So investigations would be using these to look at those biochemical disturbances, look at the calcium, do a BM. You can do the short synaptin test, so at 9 a.m. in the morning, giving a small, it's 250 micrograms of synaptin to look for response to that, and then you test the ACTH and the cortisol levels 30 minutes later. You can look for autoantibodies, and then the treatment is steroid replacement, so hydrocortisone and fludrocortisone. And then, I don't know if I've got a slide about it, but yeah, so Addisonian crisis is the really important bit. So that's what people wear the kind of the media alert tags and things. So it's for people with adrenal insufficiency. They get otherwise unwell or involved in trauma or have surgery or whatever else, and they are unable to mount a response to that. So they present, which we would do if you've got normal production. So you've got, present, they can be shocked, weak, confusion, coma, hyperglycaemia. So it's kind of the treatment is or the assessment is just your normal A, B, C, D, E assessment. And then investigating it if you don't already know that they've got this Addison's disease, and then you need to replace their steroids because they're not producing it in reaction to a stress like we would, and then septic screens are looking for the cause of what's triggered their crisis, and then obviously if you're worried about sepsis, then empirical antibiotics. And then I've got a few things that I haven't obviously covered in the talk, but you could add to your endocrinology if you want to do so. Parathyroid disorders, hyper and hypo, MEN1 and 2, which are kind of collections of autoimmune and endocrine disorders, hyperprolactinemia, acromegaly, and diabetes insipidus, both nephrogenic and cranial. So they're just things that if you wanted to extra reading, you can look at. So just before Pete takes over, I've got just a few questions. So we spoke at the very beginning about the need for annual retinal screening for people with type 1 and type 2 diabetes. So we've got 3 features of background retinopathy. So it's classified into kind of a few different stages, and background is what you'd identify first. So does anyone know any of the kind of specific background features? Yeah, great. Dot and blot hemorrhages. Pardon? I think that's the next stage. That's kind of pre-proliferative. You'd get that in. Yes. I think again that's your pre-proliferative stage. But the next one is you get hard deposits. So it's kind of the lipid deposits you can see in the back of the eye. And then how would you define proliferative retinopathy? There's one thing that kind of defines it as the next stage. Yeah, exactly. So if you see new vessel formation in someone with diabetes, then they need urgent referral to ophthalmologist, because that's your proliferative retinopathy. That's going to affect their sight quickly. And we've talked about it should be annual screening. I'm going to rush through this a little bit because I'm running over. But so and the last one is just a quick case. So it's someone with a 46-year-old man who's seen in clinic and referred from his GP with resistant hypertension. So his using knees are abnormal. He's got marginally high sodium, low potassium. He's also found to have an abnormal ECG. What's the most likely diagnosis, do you think? Yeah, so he could have Conn's disease. And then what do you think we would, so given that that's what we think and he's got hypokaleamia, what do you think we might see on his ECG? What might be the abnormal findings? Yeah. Or inverted, flattened or inverted T waves. You can also have ST depression, a widened PR interval, and peaked P waves. It's kind of all of the opposite of the worrying features of hyperkalemia, really. And then, can you think of any other? So Conn's disease, in reality, is quite an uncommon cause of hypokalemia. What are some of the more common ones? I mean, hypokalemia is something we see daily on the ward. What do you think the more common causes are? Sorry? Yeah, diuretics, yeah. Yeah, yeah, fluid loss. We talked about one earlier. Again, it's not that common, but yeah, DKA, good. And then respiratory salbutamol nebs can give you hypokaleemia as well. So I'm sorry some of that was a bit rushed, but after I'm sure we've finished, if you've got any questions, just come and give me a shout. Okay?